Okay, so it's great. I see we have folks from Edmonton, which is pretty probably pretty cold. I don't know. It's cold here too. Hello, Gil, and from Morinville. I don't know where that is. Maybe you can let me know. I bet you that's in Alberta because you're part of the MTAA, which piqued your interest, which is cool. Orlando, Florida. Oh man, I wish I was there right now. Functional medicine clinic. That's pretty cool. And a nurse from London, Ontario. That's awesome. Canmore, Alberta. It's beautiful out there. Naturopath. Oh, Vicky, by the way, I'm doing a webinar on dogs and cats next month. You'll be happy to know. Occupational therapist, which is awesome, from Niagara Falls and Oregon, United States. Cool. Betsy's from Halifax, Nova Scotia. Hi, Betsy. And we have folks from Vancouver and Grenville, South Carolina, or Greenville, I guess. Let's see, and Newmarket, that's not too far away. Winnipeg. Did the Jets lose last night? I'm pretty sure they did, but that's too bad. Peterborough. Okay, that's awesome. All right, so let's I can keep going on there. So this webinar is recorded. All my webinars are recorded. If you want to watch a webinar again, you will get a link to it within a few days to a week of it being broadcast. If you want to join in, or if you want to watch a webinar but can't watch it live, just register and you will be sent an email. And if all else fails, eventually they're uploaded onto our website as well. If you have any questions, I already see one from Lisa, which is great. I will get to the questions at the end of the webinar. Type them in the Q&A box, not the chat box, because it's a Q&A that I look for questions at the end of the webinar. Those of you who don't know me, I'm the medical director at BIOFLEX Laser Therapy. David, I'm a chiropractor and TCM acupuncturist. Been practicing for well over 30 years now. Time flies. And my interest in laser therapy has been well over a decade now, using it clinically and in research. It is an incredible therapeutic tool to use on your clients, and let's get into it. Today's topic is obviously wrist sprains and fractures. I wanted to revisit this topic because, number one, it's a common injury, especially this time of year with the snow and the ice, that kind of thing. You see it a lot in the elderly, in athletes. You know, I had a bad sprain and fracture of my wrist playing basketball. You know, these things happen and you see them clinically and they're tough to get better quickly. So that's kind of why I wanted to revisit today's topic. I'll talk a little bit about the anatomy and the epidemiology, pathophys, and etiology and signs and symptoms of sprains and fractures, and specifically why we'd be using photobiomodulation therapy. There's a bit of research I want to draw your attention to as well. And then we'll get into how you would use our professional grade equipment for treating fractures and sprains at the wrist. And you're always welcome to ask questions along the way. Just type them in along the way. Don't be shy, and we'll get to them. I'll get to them. I don't have anyone with me. I have a cat, but I don't know, he's probably sleeping. I'll get to them at the end of today's webinar. Okay, so the wrist complex is pretty complicated as far as all the joints. There, of course, are two rows of carpal bones. There's about 20 ligaments, believe it or not, but fortunately only a couple of them seem to be the most common ones to be sprained. So we'll focus a little bit more on those as we go along. So these ligaments tend to be pretty prone to injury because we use our wrists a lot, both in sports and, of course, when we're trying to brace yourself from slipping and sliding. So if you look at all these ligaments, now this is a dorsal view, the two that are most commonly injured is the dorsal radial ulnar ligament. You can see that's to the bottom to the left, that of course, they're named, of course, according to where they're attaching, right? Which kind of makes sense. And also the scapholunate, touching the scaphoid and the lunate bones together. Those two are the ones that tend to be most commonly sprained. So wrist sprains occur obviously when the ligament is pathologically stretched or twisted or lacerated or torn. It sounds pretty awful. Obviously, it's when there's excessive load bearing or twisting or injury mechanisms. Typically, we see these from a fall from an outstretched hand. Someone's trying to protect themselves as they fall. So that's usually how we tend to see these clinically. Of course, you'll see them in sports injuries and other types of scenarios as well. Typically, it's a sprain, but sometimes it's a really bad sprain and or fracture, which case they may need surgery. So as I mentioned earlier, the two most common ligament wrist sprains, the scapholunate ligament, you can see here, a little teeny weeny guy between the scaphoid and the lunate. The number one fractured bone in the carpal area is the scaphoid. And I had that one too, which is great. And that's because it has a really narrow neck and all the force is transmitted into that area. Whoopsie. So that's, and the ligament as well tends to be sprained. And then there's something called the triangular fibrocartilaginous complex, or TFCC for short. That's probably what I'll just refer it to, along with the dorsal radial ulnar ligament. That's on the radial side, obviously, of the wrist, sort of triangular shaped ligament, and there's cartilage in there. And that's also a very common injury as well, too. So again, as far as the most common ligament, that's the scapholunate, typically hyperextension of the wrist. That's the most common mechanism. For the TFCC, it's usually with forced axial loading. So like punching a punching bag really hard, because you would never punch a human unless you're, I don't know, maybe into boxing or whatever. Or punching walls. Again, I don't advise that. Or repetitive movements involving flexion, extension, flexion, supination, pronation, or ulnar radial deviation. You tend to see that in like mechanics and other occupations where they're doing a lot of work like that. And if this has ever happened to you, it's happened to me, where you're drilling something and the drill bit catches and it like torques and twists your wrist. It's really painful. And if you have a really like high torque drill bit, you can actually damage the ligament and that complex that way. The scapholunate complex is U-shaped. There's actually three different portions to the ligament. There's a dorsal, a proximal, and a palmar aspect. It's the dorsal one portion of the ligament that tends to be affected the most. And that's important to understand because when you're treating this, you want to focus your light therapy on the dorsum of the wrist as opposed to the palmar aspect, because you want to target that ligament, that portion of the ligament, right? That's why it's important to understand your anatomy. And so make sure you know where that ligament is, put a circle around it or whatever, a bullseye, and that's the area they're going to be tackling typically for that injury. So this ligament is quite complex. It has like intrinsic and extrinsic portions to it. You know, it tends to be an issue where the scaphoid bone is also involved and may also be commonly fractured as well. And usually it's a mild sprain, like a partial tear, and that's going to heal up pretty nicely if it's taken care of. But oftentimes they're not. The person just kind of, you know, doesn't take care of it. Or it can even be a complete tear or a significantly torn ligament, in which case it's very challenging to heal. And you may see this accompanied by other injuries, as I mentioned, a scaphoid fracture and or lunate dislocation, another common issue as well. As a chiropractor, you know, because of what we do for a living, a lot of us are prone to these types of injuries as well too, and end up causing lots of issues trying to practice with a wrist like that. Okay, the TFCC, or the triangular fibrocartilage complex, that's located in the ulnar aspect of the wrist and the distal radial ulnar joint, and it's held in place by the radial ulnar ligaments and the ulnocarpal ligaments, or UCL. Its primary purpose is to provide stability at that area of the wrist, and that cartilage allows the wrist to withstand compressive forces when applied to the ulnar aspect of the wrist, like I mentioned, like when you're punching, that kind of thing, to reduce injuries. And again, you're going to see these injuries caused by a fall or a twisting injury. The one, like I mentioned, with a drill bit, that's a pretty common one. You're obviously going to have pain at the ulnar side of the wrist. So it's important to do a good examination, try and determine where this injury is. You don't usually have to do an image. I don't even know if an ultrasound is going to be that sensitive to pick it up. You'd have to do an MRI, and to be honest, it's probably not going to really, help you out much. You're better off with palpation and examination. You will see some swelling. Obviously, there would be some pain in there, and listen for clicking. If you hear the clicking, that usually means that cartilage has been damaged as well. And you typically always check for grip strength in all these injuries, because you'll tend to see loss of grip strength. And when you treat, and as it's healing, you should see an increase of that grip strength. So it's a good way to monitor if objectively, if in fact that that complex is healing. So overall, when you're looking at these symptoms for a sprained wrist, there may be a bit of swelling. Sometimes it's hard to pick up, but always look at your wrist bilaterally to look at that. There's going to be a certain amount of pain, usually with movement or palpation. It can be persistent, especially if the person's doing things. You can imagine how difficult it will be to open jars for the elderly if they have issues with their wrist. You might see some bruising or discoloration in the acute phase, and as it's healing a little bit. I mentioned about a popping or sort of crepitus issue, especially if the cartilage is involved as well. And you might feel some redness, even some rubor at the acute inflammatory stage. I do want to remind everyone that make sure your patients aren't taking NSAIDs for acute injuries. I've mentioned this before, that last year they did a great study at McGill, and they're finding that the likelihood of getting chronic pain when taking NSAIDs for any acute inflammatory process is 2 times greater, because they block the inflammatory process. And yes, it gives relief, but it doesn't allow the inflammatory process to resolve. Which means that you're more likely to get chronic pain. And that's a big part of the problem, is people start crunching Aleve and all the NSAIDs. Sometimes people take them like literally, 3, 4, 5 times a day, and you're doing that consistently, and they're wondering why they keep in pain. That's why. A bit of research now. Again, this is medial collateral ligament. It's nowhere near the wrist, and it's a rat. So bear that in mind, but it's a ligament, and a ligament is a ligament is a ligament, if you know what I mean. Okay, so in this particular experiment, they looked to test the tensile strength of mechanically disrupted medial collateral ligaments in rabbits in the MCL. And what they found was that typically healing of the MCL reaches only 30 to 40% of normal, what's called UTS, ultimate tensile strength. It's a funny term. I would have just called it tensile strength, but ultimate, I guess, before it just shears at 1 year. So at 1 year, you can imagine if you sprain a ligament 1 year out, it's not 100%. Okay, so it may feel better and all the rest of it, but make sure you're bracing it. Make sure you don't stress it. Okay, so they did an experiment. Obviously, some of the rats were surgically transected. Some were in a control group. Some were treated with what then was called low-level laser, and now it's PBMT. And they they did biomechanical tests performed at 12 and 21 days post-transection. This is important, 12 and 21 days, okay? And that's the reason why I'm talking about this experiment. You can see they use red light. Red is okay in a rat because it's not very deep. In humans, infrared is better because it can go deeper, all right? So day 12, after transection, this is the ultimate tensile strength. Follow my little bouncing ball here. Here's a control. This is normal strength of the MCL. After 12 days, the laser treated, you can see here, had significant improvement compared to the sham. So this would have been the original kind of ultimate tensile strength when it first happened, right? You can see here it's almost improved by 50% after 12 days. And notice that the greater dosage was better than the lower dosage. They did 2 dosages, 1.2 joules per centimeter squared and 0.01. It's almost like a sham, to be honest. And they control. Now, note at day 21, oh, shoot. Note at day 21, you get a little bit better tensile strength, but notice the sham is now almost back up to where the laser treated is. So in other words, laser therapy, if applied from the get-go, is going to give you significant healing of the ligament. And eventually the body, well, in this case, the rabbit's body catches up and starts to heal as well. So the point of doing laser therapy, especially early on, is to get a head start to healing, but 50% head start of healing compared to the normal body healing, right? It's so critical. When patients tell you, well, I can't come in, I can't even move or whatever, get them in. You can do laser therapy. You can't do other things. Well, you can, but not manual therapies or maybe exercises and stuff because it's contraindicated or you don't want to do it. But you can do laser therapy right from the first day of injury and in the acute phase. That's why it's so important. So again, it's the summary and the conclusion is that yes, laser therapy does promote early healing of the ligament. After 21 days, they're about even. So it's important to understand that you treat as early as possible to get better results. Wrist fractures, in 2017, the stats were about 179 per 100,000 people. And for people going into ER, it was about 20% of the complaints going into ER. So that's a lot of problems, right? Typically, it's a distal radial fracture. That's the most common one. You fall from an outstretched hand, and it's usually the distal radius fracture, about an inch from the end or the distal portion of the bone. Here you can see a Colles fracture, a Smith fracture. I won't go into, I think everyone studied that. There's type 1, 2, and 3 fracture at the wrist, depending on if it's non-displaced or displaced. And you can see here the examples between the type 1 where it's stable, type 2 and 3 where they're shifting, and oftentimes it needs to be put back into position and or surgically repaired depending on the extent of it. Scaphoid bone fractures are the second most common at the wrist. And I tell you this right off the hop, I always tell this from personal experience, is that when you have a patient that's fallen and they're complaining about wrist pain and it hurts, get an x-ray. I don't care if you think it's just a sprain or they think it's a sprain or whatever, get it x-rayed. Because sometimes, and it's often, you will have a small micro fracture in the neck of the scaphoid and is not obvious. Okay. And it takes a long time to heal. And if the fracture goes through the neck and severs the only blood vessel in there, it's not going to heal. It's going to be non-union. And then you have two little bulbs of bone there, like I ended up with, that needs a bone graft to repair. And that's not what you want. So make sure you get that checked out. Okay, so make sure you know where the scaphoid is, find the anatomical snuff box, push in there, move your wrist side to side, and you can feel the scaphoid in there. That's where it is. Okay, important. This fracture, that's an obvious one, but oftentimes they're really small and sometimes even difficult to see on X-ray. You may have to do a follow-up X-ray to pick it up. Just a bit of a review with respect to fracture healing. Initially, there's a hematoma, then there's a fibrocartilage and there's a callus that starts to kind of put things together. Then that callus starts to turn into bone and you get remodeling that occurs. Now, I had an interesting case. I'm still working with one of our practitioners, a physiotherapist in South Africa, and been really trying to work on a ankle fracture that's not healing very well. There was some chondral cysts, and the client, who I believe is a medical doctor, even had some microfracturing to try and get the bone growing. And we've been trying to help this this patient. It's been challenging because sometimes trying to initiate bone growth, especially if it hasn't for a while, is really challenging. So I'm just letting you know they can be difficult cases, especially if they're chronic. Again, this is not a human trial, but it's a rabbit one, the tibial fracture and the effects of laser therapy. They use 830 nanometers, energy density, power density. The reason why this is sometimes important, but sometimes not important, is that You're treating an animal compared to a human. So you have to understand the translation of dosaging might be a little bit off, right? So I wouldn't necessarily use the same dosaging that they would use in a rabbit compared to a human necessarily. Okay, so in this case, they applied the laser via skin contact. And I always mention this, is that for laser therapy to work effectively, especially on a specific area, you should be touching the skin. If you think you can buy an LED panel and stand in front of it and get these kind of results, you're sadly mistaken. It doesn't work that way. You need to touch the skin. That's what all the clinical trials recommend. So touch the skin with your device. Those LED panels will burn you, by the way, if you touch them. They're not designed for that. You need medical grade, proper equipment so that you can apply pressure and get the light into the tissue. And they did it on 4 points along the tibial fracture daily for 20 days. When you're treating fractures, the treatment plan is more involved than when you're treating a sprain. I'll get into that very shortly. You can see the results here. Laser compared to the control after 2 weeks. Then after 3 weeks, and then after 4 weeks. Nice callus formation after 4 weeks, just beginnings of callus formation in the control. So significantly faster healing in the tibia post-fracture. Again, I know it's a rabbit, and I know it's not the wrist, but I just want to show you the effects of photobiomodulation. Okay, this is a human trial. Hooray. And this one looked at wrist fractures, closed bone fractures in the human wrist and hand. They use infrared, a 30 nanometers. That is the exact wavelength that we use. Notice they use 10 hertz pulsing. This is something that I didn't talk a lot about for the probe, but, and I will when I get into the laser parameters. I'm going to suggest that you might, if things aren't working the way you want them to work, is go to a pulse the laser probe, and 10 hertz is probably a good place to start to see if that's helpful. They looked at 50 patients. They were put into a laser group or placebo group, treated 5 times a week for 2 weeks. Here are the stats, the parameters, I should say. They did a total of 36 joules. They had a large spot size. And then just comparison, if similarly for BIOFLEX, if you want 36 joules, you would apply the laser probe for 200 seconds. That's like a long time, right? But our spot area is a lot smaller. So I mean, you can try long, you can try shorter. I'll give you a range to try. But typically it's at least 30 seconds, and you may have to go up from there. So look at the results. Laser group, VAS, pain scale before the treatment, and the placebo group, they're about the same, about 6 out of 10. The DASH score, the higher the score, the worse symptoms. Hand grip strength, whoops, I'm getting ahead of myself. Hand grip strength and finger grip strength. And then after treatment, so this is after 2 weeks and then 2-week follow-up after that, the laser group, the pain went from a 6 to a 3.84. In the placebo group, the pain went from a 6 to a 4.92 or a 5. So better in the laser group. The DASH went down to about 20 from 40 and only to 34.4 from 41 or 40-ish for the placebo. And then again, similarly, better results with the grip and finger strength. And then you can see those effects were carried over and continued on with the follow-up after 2 weeks. So obviously the results were that laser was very helpful for treating these fractures, and it can help with pain and all the movements and the grip strength in the human wrist and hand for fractures. Okay, so why photobiomodulation? It works in many different ways. Experiments have shown, in vitro experiments have shown it can proliferate and differentiate bone formation. It can help with alkaline phosphatase activity, osteocalcin, and rank, which has to do with formation of cells. In vivo, In animal models, it's been shown to accelerate bone formation, organization, and repair. You can't really do these experiments in humans. Bending stiffness and maximum force, you can see here it has an effect on different, what's the word I'm looking for? Oh, not endorphins, but leukotrienes and cytokines and chemical mediators. And in clinical trials, it's been shown to improve bone regeneration, just like what I've showed you, postural stability and proprioception and pain and function improvements as well. So that's what the research has shown. In general, bone tissue obviously has the ability to heal itself, but 5 to 10% of fractures can result in delayed union or non-union, which you come across. And that's very challenging. We know that photobiomodulation has an effect on the synthesis of DNA and RNA and the metabolism of the cell, and therefore cell proliferation and regeneration and repair. That's why it's really helpful. So it can do all sorts of things, including upregulating these growth factors and genes that are involved with bone cell differentiation, osteoblast proliferation and activity, earlier recruitment of inflammatory cells, and granulation tissue and deposition of newly formed bone at the site of injury. So these are all the benefits that it's been shown. It can stimulate, the key for bone is it stimulates these osteoprogenitor, kind of like stem cells, to differentiate into the osteoblasts and thus increasing the rate of bone formation and bone ingrowth. We see tremendous results with fractures, again, provided that you get to them relatively quickly. They have to be in a removable cast or a splint or a walking splint or a removable cast. So ask the client if they can get that kind of cast put on if they have a regular cast. So it also helps with soft tissue healing as well. At the wrist, it's pretty easy to get to, like I say, provided that they can have a removable cast. Another option, although I don't know how great this is to have a little window or hole that you can get the laser probe into. It's not ideal, but at least you can get some light into there. So sometimes they're able to do that at the hospital. As far as the treatment plan goes for a fracture, you do want to do daily treatments if possible for 4 to 5 days a week for at least a couple of weeks, I would say, similar to that one trial, and then follow up by about 3 times a week for 4 to 6 weeks. This all depends on how they're healing, of course, right? And then you want to do x-rays, although do x-rays to verify callus formation. Oops, what did I do there? Not what I wanted to do. Come on. We do have a wrist and hand wrist protocol. You can see it right here. It gives you frequencies on a low and high range. That's pulses per second. Duty cycle for infrared, which is basically a dimmer switch. Lower the duty cycle, the lower the energy. Higher the duty cycle, the higher the energy. So I think anyone that's, why is it doing that? Anyone that's familiar with our protocols understand what these are. And if you're new to BIOFLEX, if you take our certification training, you'll understand a little bit more about these parameters as well. So there's different ways of positioning the array, but I want you to position it so that it's both on the palmar aspect and the dorsal aspect of the wrist. You want to circle it. Now, if it's a really super small wrist, and you have a long array, you can probably do one. But more often than not, you're going to treat one side than the other side. A little bit of overlap is okay, but you definitely need to do circumferentially around the joint. You can do it vertically, you can do it horizontally. I don't know. It doesn't matter as long as you treat both palmar or volar aspect and the dorsal aspect of the wrist. Now, laser probe. By the way, if you're new to BIOFLEX, these arrays promote are more of a superficial aspect to treatment. They're not going to go deep into bone, but they will help with the soft tissue damage, the inflammation, and promote a systemic effect in the blood circulation that will go deeper into the bone. But its main job is to reduce swelling, reduce inflammation, and help superficially with the tissues. When you're using the laser probe, that is targeted to those specific ligaments or the fracture area, the injured soft tissue. Now, for targeting bone, it's tough to get light into bone, right? It's denser. So you may have to hold it, well, you should be holding it for longer. 30 seconds up to maybe 200 seconds per point. It's a long time. You can play around with that. I mentioned about changing the frequency. Usually it's a continuous wave, steady stream of light. But if you're finding it's not coming along as well as you'd like to, you can pulse it out as well. And I'd recommend at maybe 10 hertz. You can go all the way up to 250 hertz as well too. If you have the red laser probe, again, not going to go into the bone, but it's really helpful for analgesia and reduction of pain. So if you don't have that in your arsenal with BIOFLEX, I would pick that up if you have a chance, just because it's very helpful for pain control in all locations that you're treating, because the light is super, it has a lot of energy density in a very superficial area where the nociceptors are. So it kind of blocks them out and gives you some nice pain relief, or the patient pain relief. For ligamentous injuries, treatment plan is a little bit different. I'm going to recommend initially, especially the acute scenario, 2-3 days in a row, and then go to every other day, so about 3 times a week. Again, people ask, well, do they have to come in 3 times a week? It's like, well, I mean, you know, best results are 3 times a week, twice a week minimum. And if that's a problem, then you should be getting some rental equipment and also rent out your equipment to your clients that can't come in all the time, make some extra revenue, get the patient being treated, have them come in for the laser probe. It's a win-win, and you make, you know, a bit of extra money on the side there. If you're not sure how that works, speak to one of our account executives and they can walk you through that process as well. Oh, by the way, if it's a cartilaginous TFCC injury, you hear that clicking in that location on the ulnar side, that will take a long time. I guarantee you that. And sometimes it doesn't heal very well, and they're left with that clicking or popping. As long as it's not painful, it's okay. But, well, it's not great, but it's just going to be there. So a little bit less dosage for the probe, maybe 5, 10, 15 seconds per point for the probe using the LDI 200 and the soft tissues. And again, you can use the red laser probe as well. Okay, right on time. So upcoming events, I'm out in Vancouver. When am I in Vancouver? On March the 25th, we're doing a live Light Up Your Practice. And I'm having guest speakers, Dr. Lauren Brown, acupuncturist, expert in fertility using laser therapy, as well as Dr. Pierre Delorier, I don't know if he's listening in today. He's been using laser therapy for quite a while now, getting tremendous results. He's a tremendous speaker, and he'll be talking a little bit about incorporating laser therapy into his practice, but also some of his incredible case studies and how he has a great system. He uses co-op students to do a lot of the grunt work. They get experience. He gets free labor. It's a win-win. So if you're in BC and you'd like to learn a little bit about that, come join us. I'm sure we'll sell out because it's limited. We're at the top floor of the Blue Horizon Hotel. It's beautiful. You have a panoramic view of all of the harbor and so forth, but we can only squeeze in 40 people. So I think 40, 45. So if you want to come, I would register, and it's cheap, and you get a free lunch and you get to hang out. So if you can make it, come out and visit us. And we're in Ottawa, April 22nd. Can't do any of that online. I'm doing one on March the 4th and then April the 8th as well. Next webinars are treating your family pet with light therapy. I'm going to more focus on using the personal system for that, but you can equate that to the professional equipment as well. Actually, I just got a new cat, so I thought he was sick today. There's something wrong with him, but no, he seems to be back his normal self. I'm surprised he hasn't jumped on me yet. And treating rotator cuff tendonitis and shoulder impingement with laser therapy on the professional side. Those are the webinars into March. So let's take a look at some of the questions from Lisa here. Recovery with laser in patients with stainless plates, modifications, contraindications below or above the wrist. Okay, anything embedded in the tissue will not be harmed, will not heat up with photobiomodulation. The definition of photobiomodulation is that it doesn't generate heat. There's not enough energy to heat up things beneath your tissue. Class 4 laser therapy, above 500 milliwatts, heats up your tissue, gives an analgesic effect, which is great. You know, everyone loves feeling great benefits. It's like going in the hot tub, feeling great, and then 2 hours later you go, man, I feel crap again. Yeah, because it's temporary relief. That's what class 4 is. I know I sound like a downer all the time about class 4. It's great for analgesic effect. It just doesn't produce photobiomodulation therapy. You got an apple, you got an orange, they're both fruit, but one is different than the other. Oh, a link to the study in NSAIDs. I don't have the link here, Laurette, but if you Google McGill NSAID research, I bet you'll find it. And I think I have referenced to it in some of my webinars. I did one about NSAIDs, I think, actually, and I referenced this one a few webinars ago, like I think November or September or something, on our website. You can find it there. Are there any interactions of red light or infrared light with injectable peptides at the injury site and PRP? Actually, funny enough, not funny, but there's research showing that PRP plus light therapy is synergistic and gives you a better result than just one or the other. So it's actually helpful to do along with PRP. If you're getting cortisone injection, there can be a negative interaction. So let that wash out for 3 or 4 days up to a week before you use light therapy. Other injectables, I haven't seen any research or know of any contraindications, so I don't think there's any issues there. Question here or a comment from Betsy about scaphoid fractures. They're often missed on the first x-ray, not seen on the x-ray until the callus is forming. Yeah, exactly. And sometimes that callus doesn't form because it goes clean through, and that little blood, there's only one blood vessel, I believe, that goes through the neck, and it is severed, and then you don't get proper bone formation. So I completely agree. Be very diligent with the x-rays and follow-up x-rays. And sometimes, like when I fractured my wrist, I thought it was a sprain. For 2 years, I just felt like a sprain, felt like a sprain, felt like a sprain. Finally had it x-rayed, and yeah, that's exactly what happened to me. Comment here from Bonita. When I broke my wrist last year, I was in a plaster cast for 8 weeks. They had to re-break it and reset it twice. Ow. I couldn't start laser until it was back in the brace. Is there anything that can be done if the wrist is in a plaster cast? Yeah, other than cutting a little hole in there, not much you can do. I mean, to be honest, you can't get light in there. You can treat above, but it's not going to have a tremendous effect. Does the treatment regime you're giving apply to the BIOFLEX 180? Pretty similar, except there's no laser probe, Rachel. Photobiomodulation helps reduce inflammation, which must be different from the inflammation reduction due to NSAIDs, which are not recommended. What is the difference? Oh, okay. So NSAIDs block the inflammatory pathway. They're designed to actually inhibit or stop it. Photobiomodulation doesn't inhibit or stop inflammation. It helps to promote its resolution. So what it actually does is it promotes neutrophils and macrophages to speed up their process. You get an increased number of macrophages and macrophagic activity that help to clear out the dead and dying neutrophils. Neutrophils are the first responder that cause inflammation. If they persist, you get persistent inflammation. They need to die down. Then you need to get macrophages and other blood cells to get in there to start to get the process going. So what the light therapy is doing is it's actually promoting that. So it's shortening the inflammatory phase, not stopping it. And that's the big difference there. And that's why NSAIDs are really don't take them. 1 or 2, fine, but you're better off taking like a Tylenol or something that maybe masks the pain, but not affecting the inflammation. They will never let you know that. Just look at the research. It's really compelling now to show that you shouldn't be taking that for chronic pain. Or for acute pain, it just makes it worse, and for chronic pain. I think that's it. Oh, what if a wrist fracture requires surgery? Is there any benefit post-surgery other than the wound healing? Yeah, definitely. I mean, for post-surgery, you're looking at helping, obviously, the wound healing aspect, but where that surgery is occurring with the bone formation, like presumably there's screws and the bone's trying to reform. So similarly, it's going to help that area heal, plus all the soft tissue injury that occurs due to surgery as well. And you can treat post-surgery the day after, even the day of probably. You can treat over sutures, but not over bandages. If there's a bandage that can't be removed, treat around the bandage. That's what I would say for that. How does it work on chronic pain? Well, you see, chronic pain, so what happens with chronic pain? There's different things going on. You can have a desensitization of the neural pathway. So there's no more inflammation going on, but the neurons are still lit up, thinking that there's a problem. And so that's called chronic desensitization or sensitization. Oh, I can't remember now. It seems to break that cycle. You treat at the spinal cord level as well. So that's what I would do for chronic pain. They're notoriously the most difficult and challenging conditions to deal with. Sometimes you have to use shockwave or ART or other kinds of therapies to kind of, get the area kind of back into an acute stage and then heal it. And sometimes that does a trick. It hurts, but it's helpful. I like shockwave, but it can't be used all the time. If I were to choose one or the other, I'd have laser therapy first. If I could choose two, I'd choose shockwave and laser therapy. And the third modality I would go is probably PEMF or PEMF. Those three, I think, are the best ones out there. Laser's number one. PEMF is good too. I don't know. PEMF and shockwave are good too. But we don't sell PEMF or shockwave, so I'm not going to comment too much on that other than it's true, they are helpful. But not as helpful as laser. Do we use the full wrist protocol in both the palmar and dorsal sides? So essentially treating the wrist for almost 60 minutes. Yeah, so Keith, you would just probably treat one array on the dorsal side, on the palmar side, one array on the dorsum side, volar side, dorsal side. I forget the timing. I think it's like 18 minutes. But if you can run two arrays at the same time, or wrap it around that, then it doesn't have to take that long. Which is why we have dual port and multi-ports now, and you can do two arrays at the same time. So the treatment time should only be about maybe 20 minutes max. Yeah. So true, you can treat, the comment is, I think Dr. Ben-Ewan said he has good results applying PBMT above and below the casted wrist. It all depends where it is. If the casted wrist is up to the fingers, you're limited there. Treat above it for sure, that will be helpful. Ideally, the cast is removed. You can still treat it. I mean, the results are probably going to be okay, but not nearly as good as if you can treat directly over the area. So still treat that area if they're casted, but I don't think you're going to get as good result with that. I think that's it, everyone. So I remember I asked for questions in the Q&A. Now I have to go to the chat box. Okay. Oh, awesome. So Lisa was commenting that she had used laser therapy and the surgeon commented they were impressed with the rate of healing. Of course, they'll never be interested in laser therapy. They just want to do their thing, but that's fine. Here's a comment. Oh, okay. I think everyone, yeah, that's all good. All right. So we're all done for today. Have a great afternoon, everyone. And hopefully we'll see you at our next webinar or live event. Next webinar is on March the 9th on treating your furry pets, unless it's a hairless pet, in which case it's easier. Take care, everyone. Bye.